Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet. I am Bob, and exactly one half of the Bob and Brad team. I'm joined by my other partner, Mike, who's going to ask the keto questions today. And our guest is a second-time guest. He's actually Dr. Mark Cucuzzella, and we'll let him explain who he is, but we're going to cover plantar fasciitis or fasciosis, depending on your perspective, and also keto, the keto diet. So enjoy. Mike, we're going to talk about keto now.
Yeah, I brought on because I eat keto too, so that's why I'm here. So we'll just start with this. Mark, why did you switch to a ketogenic diet? Because you, like me, were not originally eating that way.
Yeah, I got diabetes, so it came pretty, like I was kind of blindsided me, but not blindsided as I looked backwards. And there's two types of diabetes, type 1 and type 2. Type 2 is the common type we see where you become insulin resistant and your body's trying to store all these carbohydrates, cranking out more and more insulin, becoming obese, fatty liver, so that's the common variety we see. And then there's the other type where you don't make enough insulin. And that was the type I was developing. And I had blood tests when I was on military duty, which put me right at the full diabetes spectrum. And I looked like this and, was running 60 miles a week and winning races. But I was waking up at like 2 a.m. every morning, needing more carbohydrate because I would have this spike and this crash. I'd have a little bit of a delayed insulin response, but my insulin response was almost completely gone. Put a continuous glucose monitor on and saw what was happening real time. And basically in 72 hours after wearing that glucose monitor, turned the food pyramid upside down because to maintain military service, you cannot be diabetic, right? You can't be on medications or else. And I'd done work, Mike, with the DOD and the military, for that year prior on the fitness test and working on really obesity was one of the biggest drivers of people failing the test. So during that year, I dug in deep into the literature of obesity and the science of obesity, and really just observational experiences of military members traveling to all these bases. And whenever I'd go to a military base and ask if anyone's lost 50 pounds and kept it off for a year, I'd get maybe one hand, and it might be someone like you, Mike, and I'd say, "What did you do?" And across the board, it was always the same answer, something similar to, "Well, I did, got rid of all the bread, I got rid of all the sugar,
Right.
I did paleo." And,
Yep.
11, 12 years ago, paleo wasn't an aisle in your grocery store. That was like,
Right.
eating animals and plants. And a gutsy person might say they did Atkins, right? That was a doctor. They're afraid I was going to yell at them. And Gary Taubes' work was out there. So I knew the literature was sound, that eating eggs didn't clog arteries. So like having done that, I didn't have any fear. Oh gosh, I just need to eat more eggs, meat, veggies, and just get rid of all the carbohydrates. And, I was probably true. So the true ketogenic diet is probably somewhere, 20, 30 grams of carbs a day. And, I'm actually in that space and have been there for 10 years for medical indications. So not everyone needs to be in that space. So you need to figure out kind of what your issues are. I've got a monitor in my arm now, and, and it tells me where I need to be, ketone meters. And I'm always at a low grade level of nutritional ketosis. And all that means is I'm making energy from fat. I'm not trying to gain or lose weight. I'm trying to maintain my muscle mass. But, you could be a butter burner or a bagel burner. And if your body, by your own disease state, genetically, your body's not adapted to burning the carbs, then you got to switch to the other. It's like driving on the right-hand side of the road or the left-hand side of the road. So you can't do both. Just pick.
So are you saying,
which
Mark,
one
that some people can get by with more carbs?
Oh, heck yeah. Yeah. So for sure. Someone is in what we call insulin sensitive, meaning their muscle and liver are completely fine. They can throw in, half a pizza with a craft beer. Their glucose goes up a little bit, and that insulin only needs to go up a little bit, and you'll store that pizza and the craft beer, go mountain bike tomorrow. Now, if you've got a little bit of a fatty liver, that's called insulin resistance. Now the system's full, right? You're resistant. There's no room in the end. Now that person throws in, 100, 200 grams of carbohydrates. their body can't clear that as easy. So the insulin's got to start cranking up. So instead of just like a little squirt of insulin, they need like a fire hose of insulin.
Gotcha.
And then that high insulin state, insulin's going to regulate the blood glucose and create homeostasis. So it'll do whatever it needs to do to create homeostasis with blood sugar until it can't anymore. So that insulin cranks up. Now muscle and liver don't want that glucose. It's you're already infiltrated with fat. So if that's the case and the insulin's cranking up and it's got to dispose of the carbohydrate, where's it going to put them? It's going to convert it to body fat, right? That's through your liver. It's going to start shuttling it, fat trapping. You're tired all the time. You're hungry all the time.
Yep.
So if you're going in that direction, even if you're a runner, right? You're like, gosh, I'm tired. I'm hungry. I'm putting on belly weight. You know, I had a guy last week in clinic and he's pretty lean, but he's feeling more fatigued. He's in his 60s. He was like an old school runner, like from the 60s, right? You know, running marathons, like ran in college, you know, when they had dirt tracks. And sure enough, you look at him and he's fine. But no, he's, you know, his A1C was pre-diabetic, triglycerides high. It's like he's still eating, you know, the Bill Rogers diet, you know, but now he's like 70 years old. And the Bill Rogers diet was like, you know, he's just eating, you know, whatever he can because he can burn through it. Right?
Yeah.
Back in the day, right? Yep. There was no fancy sports nutrition when
that's right.
You know, Billy was winning Boston. He'd eat sandwiches and you know, chips and pizza and beer and soda, whatever he could get his hands on.
Yeah, I remember those days.
So do I.
That's how I ran in my 20s. A little different now. I had so many stomach aches back then too, but
and what made you decide, Mike, to make the switch? Like, were you having some kind of issue or curiosity?
I had curiosity, and then I always had like energy sways pretty bad, and type 2 diabetes runs in my family. My mom's actually type 1. So I have always known, you know, what diabetes is and stuff, but I went off it for a bit and I wasn't feeling as good. And I actually started checking my fasting blood sugar because I had a ketone meter, and it was actually like 105, 110 when I went back to carbs. And I was like, I feel great on keto. I'm like, I'm just going back. Like, I was like, this is stupid. But it's basically, I was just like, it runs my family. It's just easy, you know, control of your hunger, better energy, better digestion for me personally.
I brought this chart in that my wife, and she agreed I could show it.
Bob's wife is started keto last year after we had Eric Westman on.
Oh, heck yeah.
But this is his wife's chart. The blue line going up there is her fasting blood sugar before keto, and the last line is after keto.
Coming down.
That was right when she was told.
I can't read the numbers, but she was in diabetic range. It looks like, and now she's.
It was between 100 and 113 before keto, and now it's fasted. Now it's like below 80.
And she was
How
told.
Does she feel? I mean, does she feel
great,
good now?
Great. And she was told by her doctor, "There's nothing you can do. You're going to be
absolutely
diabetic."
wrong.
I couldn't believe it. I mean,
no.
I said, yeah, right. And so this has convinced her. She's so happy now.
Yeah, we just published a study, Bob, with new type 2 diabetes patients. You know, they full diabetes, right? So destined to be on medicine, lifelong disease, chronic progressive disease. And we put a glucose monitor, one of these things that I have on my arm, and if this is the thing, you can see it, and gave them a little guidebook. And we had a psychologist just do a couple sessions teaching them how to use the guidebook of how to monitor their sugars and assess food and activity. And in 4 months, 2/3 of the patients made their type 2 diabetes go away.
Wow.
Meaning by American Diabetes Association definition.
Wow.
And hemoglobin A1C average reduction 1.8.
Fantastic.
Wait, there's no medicine, right? Like, wait, that should not happen. But it just makes the case that, look, this can happen. There's hundreds of publications now in this space, because type 2 diabetes is a dietary syndrome of carbohydrate intolerance. It's treated by reducing the carbohydrates and reducing the insulin resistance. So that's absolutely. Like, if we don't speak there, but I think what both of you have nailed, or with your wife there, Bob, is there's this thing called the gut-brain axis, which I think will be the next frontier. So that the gut isn't just some tube to digest calories and carbs to run. There's all of this hormonal response from food, which affects our mood, affects our energy, affects our
Yes.
hunger. So like people discount that, like, well, I'm not hungry anymore. Like, well, so what's that mean? I mean, you're getting different. I mean, would you say that's true, Mike? You just get a different like mood response with food. You don't have
Yeah.
this, and it's hard to put your finger on it because what you feel is probably different than what I feel.
You lose your addiction to like certain things. Like I was pretty addicted to sugar, even when I try to eat clean carb sources. Like you'd still get those really harsh cravings, and now that's gone. I don't like practice intermittent fasting on purpose, but it just happens. Like most days I don't eat till 10 or 11 in the morning. I'm usually done eating by 6 or 7. Like I'm just not hungry, and I don't see the point in forcing myself to eat if I'm not hungry. So,
and how's your energy running? Just
it's good. It's great. It's like because I used to be eat a big meal, sit around for 2 hours, and then run. And your stomach was kind of a mess. And now it's like just run fasted. I have coffee, maybe electrolytes if it's a long run, beforehand. But it's like you could just go. I mean, I like to eat.
Yeah, heck yeah.
If I lift weights like hard, I like to eat before that, but running I don't. But that's
it's always predictable. It takes, like, if you're an ultra runner, even a marathoner, it takes a big kind of problem out of the equation, right? People, my stomach goes, right? Because they have this nutrition plan. And if something doesn't work out with that, like their race is a mess and they've wasted 4 months of training. But the beauty of low carb is you don't need a nutrition plan.
No,
you need an electrolyte plan. You just get salt in your body and fluids, but you don't need like a nutrition plan unless maybe you're doing a true ultra or something. You're going to be out there like 4+ hours. And then you got to figure out how to get some calorie in you. But other than that,
last year or December, I ran a marathon and it had more elevation than I was expecting. But it was, I went fasted into it. And then like halfway through, because it had like 1,600 feet of elevation total throughout it, but it was like spaced out. I like brought carb gels in case I needed some quick glycogen during it. And like, that was fine because I only took like 2 of them way into the race because I could feel like my hamstrings are getting really tired from those inclines. But yeah, I mean, it's just kind of strategy, I guess. But
and practice it. If you're listening to this, don't go out tomorrow not doing low carb and say, I'm going to do low carb and go run 4 hours, because you have to train your body.
Yeah, it takes a while.
I bugged. No, it takes sometimes months to really, like, depending on your metabolism, to really make that switch.
Yeah. Do you maybe want to talk about how keto has changed your approach to how you run your clinic and your patients?
Oh, yeah. So 10 years ago, came back to the hospital after dealing with my own diagnosis and figuring that out. And I heard Tim Noakes speak. I was given a sports med conference with him down in South Africa, and most people probably heard of Prof. Noakes. And I hadn't kind of come out yet that I thought this was applicable to all of my daily patients. When I kind of knew it probably was, but you're working in an institution that still thinks eggs are going to cause heart disease, and I'm just a GP. But Tim gave this talk, and it was like a 2-hour talk, and he's like, well, this is the first time I've really spoken about this, and he went through his own path of diabetes, and what he read and learned. And he's like, well, it's been about 5 years, and I think it's safe to talk about this now, because I think I'm right.
Yeah.
He never says he is. He says, but it took him 5 years. And if you know Prof. Noakes, he's written 1,000 papers, so, and then he gave this 2-hour talk with, 100 scientific references, historical references, and the food pyramid, and how that came to be. Like, just basically, this was it, right? It's like, oh my God, like, I'm not crazy, because, like, I'd been thinking all this myself. And then I came back to my hospital and proposed we change menus for diabetes patients, and after some headbutting, they actually agreed to have a 10-gram carb per meal option for diabetes patients. And if you think about it, in most hospitals, if you have diabetes, the standard diet is 60 grams of carbohydrates per meal.
Wow.
And if any of you out there actually has diabetes and has a glucose monitor on your arm, go eat 60 grams of carbs.
Yeah.
10 grams raises your sugar 40 milligrams per deciliter, right? So you're just, we're blowing up people's blood sugar and giving them insulin on the side. So it took some resistance, and they were kind of terrified of doing that. And I said, look, I will be there. These, we're just going to watch them, right? And didn't, obviously there's no harm in that, because the menu is that, double eggs, double salad, extra eggs, right? It wasn't like we fed them a start. There was basically like a well-formulated low carb diet, eat plants and animals, and wasn't a calorie restricted in any way. They couldn't even finish the meals, but it didn't have carbohydrate other than some of the leafy vegetables, and the blood sugars are stable. And then the next concern was, well, what are they going to do when they leave the hospital, right? Because if they learn this and then they go out and go talk to their doc, and they're like, oh, that's crazy. So they actually allowed me to open up a clinic here doing this,
Awesome.
So my clinic is where I'm standing right now. So, even though I am an outlier within our institution,
Yeah.
this is still not even close to generally accepted or standard care. I am allowed to teach carbohydrate reduction, take people off medicines. I follow people on glucose monitors, and we land the plane, right? We pull them off their insulin slowly, but we watch all the parameters. And there's no downside to this. Like, if someone would show me that there's a downside to reducing liver fat, reducing medication, reducing belly fat, their blood pressure gets better, their lipids, everything gets better, right? And I don't take their stomach out, right? Like, it's not bariatric surgery. It should be an option, for every patient, and they can choose what to do, but it's not offered as an option, for probably 98% of people who come in with type 2 diabetes.
Exactly.
Just like you said, your wife there, you're going to ultimately get diabetes and be on meds.
Yeah,
and if that's what you're told, you might actually believe that, go home and eat your bread and just say, well, I guess, I'm smoking and I'm going to get emphysema and I'm going to die, right? No, stop smoking, right?
Right.
It's like, no, we need, and we're going to help you, right? We're not just going to tell you that. And that's maybe what differentiates my practice. Bob, is, I gave a talk with Eric Westman a few weeks ago, and I was like, what am I going to talk about that's different? And really my whole topic was called compassion in medicine, because I think that's what's gone. We all talk about I train med students in empathy, you feel their pain, but that doesn't engage them in the way. Compassion is, I understand what you're going through, and I'm going to do everything I can to help you. I will do everything I can to help you, right? Every patient I see has my text message. I put glucose monitors on them. We are going to do everything we can to help you. You're having trouble calm. Like, we will do everything we can to help you. We are all in to help you. And they appreciate that, because this ain't easy.
No,
it's like giving up, we're in the opiate belt here in West Virginia too, right? So if we're going to help people get off opiates, right, they need full support.
Sure.
Mm-hmm.
100%. So we want to help people, and that's what we try to do here. That's why we publish papers and do research too, because people bully you and they want to tell you what you're doing is dangerous. So you just go write the papers, right, and do the research and show that.
That's what's so strange to me, is the research is so solid.
The research is like crazy solid.
Right.
It's
Dr. Westman said that. Right?
Yeah, it's pretty good. I mean,
this was a
doing
drug,
half the studies.
Right.
Yeah.
People don't question
if low carb
it.
was a drug, it'd be a bajillion dollar seller, right? Like, it's the biggest hammer for even depression. When people are diabetic, they're depressed.
Yeah.
And we even saw that in our little pilot study. The thing that moved the most was their depression score.
Yeah.
Forget about their blood sugar.
It is it's a big mood changer.
Yes,
I mean, I've always been pleasant, but like, there are times I really had to put on a face, especially like, because we worked with elderly patients and you have to have patience with them. And like, once I went to keto, it's just like night and day difference. I don't even like need to sleep as much at night. It's weird.
Sure. Mark, we're coming up to a hard stop here. Do you have time for one more question? Or
Sure. Yeah, I can go a couple minutes over here, but that's cool.
Take one more.
Then we have got patients putting in the room, but this has been fun. Nice little lunch break.
Sure. So like, what are some lab values you typically look at that other doctors don't? Because everyone always hears cholesterol is terrible and other stats. What are things you commonly look at?
So most people can look at their own labs without any fancy labs. One is just a hemoglobin A1C, right? That's your 3-month average sugar, right? So they say, well, normal is about 5.0 range, and they say pre-diabetes is 5.7. full diabetes is 6.5. So the more you're trending toward pre-diabetes is like being a little bit pregnant. So as soon as you're there, you have diabetes, right? It's not like pre-diabetes,
sure.
you have it. So that's a marker. You can look at your triglyceride level. So high triglyceride travels with the prediabetes. Genetically, some people will gain 100, 200, even 300 pounds before they become diabetic because their insulin keeps cranking up, packaging away, but they're not diabetic yet. They're just very good genetically at becoming obese. And then you might be a South Asian and you won't become obese and you'll have full diabetes at a normal BMI. So looking at that triglyceride level is really important because that's just a marker. And in the literature, if you look at what cholesterol markers travel with heart disease, it's high triglyceride blows them all away, as well as low HDL, which goes along with the high triglyceride. So that triglyceride to HDL ratio is what you want to look at. And ideally, you'd want your HDL to be higher than your triglyceride. Has much more validity. LDL by itself, without looking at those other two markers, means absolutely nothing. So if you have high LDL and diabetes, right, you're in trouble. But if you have high LDL and you're uber well, I have high LDL. I have a coronary calcium score of 0, but my HDL is 110 and my triglycerides like 70, so I'm fine, right? I'm just trafficking lipids around my body, but someone else might be different. If you really want to know, okay, about this insulin resistance deal, you're putting weight on in the belly, get a fasting insulin. Just you can order those online. You don't even need your doctor to order. Go to like Ulta Labs is a site I use, and it's like a non-transparent menu, right? You can just, I want this test, I want this test.
That's
Vitamin
cool.
D might be another one if you're going to go spend $20, because you guys are up in Minnesota, right? Like it's probably hard to, if we just went into like your town and just did vitamin D levels, probably most of them are going to be pretty damn low.
Yeah, especially winter getting over it is.
Yeah, so maybe that one. But those are really and then your waist circumference, you don't even need a lab, right? So the markers of the metabolic syndrome, insulin resistance, heart disease, they all travel together as waist, increased blood pressure, high triglyceride, low HDL. And then what your wife had there, impaired fasting glucose, even without the A1C. So fasting glucose greater than 100 is abnormal, meaning you're trending. You want that. So again,
she was,
yeah, that's where she was. I don't know what her triglycerides were, and I'd be curious. I bet her triglycerides are down now, and her HDL is up, and her waist, like all these other markers.
Right, you're absolutely right.
Are gonna. And probably if you really want the test of truth, because, who cares? Pre-diabetes, cholesterol, what do we care about? We care about cardiovascular disease. That's the leading cause of death of men and women, far and away, right? And that includes stroke, right? So we're talking about heart disease and stroke, so that if people are wondering, okay, where do you stand? You just go get this $99 test called a calcium score. And that test will tell you anywhere from 0, meaning you got absolutely no plaque on your arteries, to, holy S, right? You got a ton of plaque on your arteries. So sometimes, like, do you want to aggressively treat something to prevent heart disease? It's good to know, well, do you have heart disease or not?
Sure.
Very
helpful. That's what a CT scan is, right?
Yeah, it's a coronary artery calcium. It's done by a CT. It's like a 30-second, dye. It's like the mammogram of the heart. No radiation more than equivalent to a mammogram or 2 chest x-rays or a transcontinental flight. So there's and very low cost.
And your calcium score
$99.
can change, even if you have plaque buildup. Like if you go on a diet, it can decrease, because I've seen people post about that. It's not like it's permanently.
And the people posting about that, like, they probably don't know what they're talking about, because the calcium is a scar. So if someone, and it's usually tied to some kind of supplement or program. So when you have a scar, what you want to do, so what calcium is, they're injuries. They're small scars in the arteries, soft plaque ruptures to create a scar. That's the calcium that you see on the scan. They're like little injuries. So if I've got scars on me, I can't make them go away really, but I can stabilize them and not add new ones. So the goal is, if you have a score, you've got calcium on your arteries, is lock down whatever contributed to your calcium. And that could be just stress, maybe your own relationship issues, kid issues, family crisis, financial crisis. like night shift work, right? Like there's a lot, find a good clinician that can figure out why you got that calcium. Well, maybe I smoked 3 packs a day in my 30s. Now I've quit, right? Well, that's like a done thing. Just don't keep doing that.
Sure.
So this is why you need clinicians to help have conversations with you.
Yeah.
And not just like put you on things, right? So it's always a discussion. But no, that's like another whole topic, the calcium score, but understanding when to use it, how to use it, what to do with the results. And don't let it scare you. It's just information that, and I think the most powerful thing, Mike, about that test is we're all go to the doctors and we're all going to leave there afraid we're going to die of something. We're always adding risk, right? So if your score is 0, right, we can look in the eye and say, Mike, you're good, right? It's cool. You're good. You're fine. Go run. My score is still 0. Knock on wood. I had it done a couple months ago. I get it done every 5 years. That's our military standard. We would do it every 5 years. Pilots, so I'll just keep doing that. Probably until I really get to old age and then just stop doing it. But yeah, so that's, you almost have to do that to defend what you're doing. So people will say, "Oh, eggs clog your arteries."
Right.
I was at this conference with Eric, and I've probably had 5 eggs a day for the last 10 years. And you kind of do the math there. So if eggs clog arteries, at least for my N of 1, and if I've had 5 eggs a day for, I don't know how many zeros that would be.
Yeah.
Wait, I don't have any plaque on my arteries. So eggs do not clog your arteries.
Sure. I have 3
Everyone's there. I don't want to.
You only have 3 a day? I have
only
like
3?
Yeah, I have a lot more than that.
Beef up. Dr. Mark,
It's
thank you
been
so
wonderful.
much. Great information.
Thank you for the
as
massage
always.
gun too. After the last show, a friend of mine stole it, so I had to go get another one.
Oh God, you should tell me.
We can send you another one.
Not in a negative way, but yeah, because you loan it to someone who, I got this SI issue here.
Sure.
You loan it, and that's the last time you see that massage gun. They work.
Yeah.
We got some other models. We could send you a different one.
Yes.
Yeah. Yeah, they have ones with like heat. No, but heck yeah, they work. We use them for fascia therapy.
Yeah.
And thanks for sharing my book and reading it.
Yeah.
Likewise.
We can
Terrific.
do,
Terrific.
Another follow-up on a topic of interest if you've got one later. It's always fun.
Absolutely. You're a fount of knowledge.
So we'll put everything in Mark's store and website and book information down below. If you're watching, if you're on podcast stuff, I guess just look somewhere in description. But
we'll see you, Dr. Mark.
See you, Mark.
All right. Guys, have a great afternoon.
Right.
Stay warm. Spring's coming.
Sounds good.
All right.
Hope.
Okay, Bob, Mike. See you.